itself. And in particular, we're going to record this lecture. And here's the thing I want you to fully understand. Whatever you do as we move through the rest of this semester, don't stop reviewing, Travis, your EKGs, okay? Don't stop reviewing those, because the plan will be from here until your final exam is that you will have an EKG quiz at the start of every class. Now, there may be a few times when you don't, but that'll be the exception and not the rule. Okay, so just go ahead and plan on the fact that you're going to have an EKG exam. But now, again, as we're moving into what we're talking about today, we're going to begin talking about pathophysiology of the heart. What happens when the heart begins to fail? When there is a blockage, Carson, in the coronary arteries, when tissue begins to die. Now, how does your patient begin to exhibit? So this part right here, in addition to your information that we've covered in your rhythm strips, we're beginning now to bridge you over into your advanced sequence. And so, again, like I told you at the beginning of class, everything that we talk about in this class from week to week builds on itself. So, again, when I tell you this content is really important, this is going to be very, very important for you as well. All right. We are recording. I'll make the recording available to you just a little bit later on today. So if you want to avail yourself of it, that will be great. So as we're looking at here and we're talking about our patients, keep in mind that your patient that is having a heart attack will present in many different ways. And you see some of them up here, okay? You can get a 45-year-old male that's got crushing substernal chest pain. When we talk about substernal chest pain, sub meaning under, sternal meaning the sternum, the breastbone. And so that's how you're going to report it, that substernal chest pain that is underneath the sternum. That is your classic presentation, along with some of these others, as far as how a person will present, okay? The classic presentation is a male, middle-aged or older, substernal chest pain that will radiate to the left or the right arm up into the jaw. They will also have nausea, vomiting, and diaphoresis. Diaphoresis is, tell me more, sweating that is what? If it's 90 degrees outside and you're sweating, is that appropriate? Yeah. If it's 45 degrees outside and you're sweating, is that appropriate? No. So diaphoresis from a cardiac perspective is sweating that's not appropriate, okay? Which makes it very difficult because sometimes you will have folks that are having MIs, Catherine, outside in the heat, okay? So it's kind of like, are they sweating because they're hot, or are they sweating because they're having a heart attack? Now, at the outset, I want to stress something to you, okay? If you've seen one heart attack, you've seen one heart attack, okay? One MI, you've seen one MI. MIs can present in multiple different ways. Let me give you an example. We've talked about the classic approach to the MI that I just described. Let me tell you, ladies, y'all don't play fair. Men, just go ahead and admit it. They don't play fair, and ladies are smarter than us, okay? Trust me, they are, and you will be much happier, all right? When you all have heart attacks, do you know what the most common symptom is for a female who's having a heart attack? Say it again? Nope. Nope. Tiredness. I'm tired and I don't know why. Now, for the last week, you've heard me talk all plugged up and everything. And my wife is a nurse. She's taking very good care of me, but she reminds me, and she's right, again, notwithstanding the fact that she married me, my wife is the smartest person I know. She reminds me that I'm suffering from a man cold, which is entirely different than a lady cold. And I agreed with her, and I said, "Yeah, I'm going to go over here and lay down on the couch. If you had this cold, you'd be out front pressure washing the driveway while you had this cold." My wife can work circles around me. Okay, and many times, she'll finish up the day and she'll say, "Well, I'm tired." Well, yeah, you got a bunch of reasons for it. I mean, you're a nurse and then you come home and you do all this other stuff and you work in the community and everything. But if you have a female or a female or a diabetic that has a sudden onset of unexplained fatigue, immediately a little model of, we have the devils that pop up on her shoulder, but a little model of Dr. Young should pop up on your shoulder, Travis, and say, "Hey, check and make sure she's not having a heart attack." So that should come into your brain the very first thing. Wasn't long ago, one of my students from last year's cohort came back and told me the exact same thing. She said, "We ran out on this call, went to this nursing home. The lady said, 'I'm tired and I don't know why.' And she said, 'Immediately I heard your voice standing behind me.' And we ran a 12 lead on her." Actually, no, it wasn't a nursing home. It was a 45-year-old mother. That's what it was. A 45-year-old mother who said, "I'm tired and I don't know why." And they ran a 12 lead on her. Saw she was having a heart attack. Started taking her over here to Baptist Richmond. On the way, the lady went into cardiac arrest and they defibrillated her. Today, that lady is back home with her family, taking care of them. So again, females and diabetics, we'll talk more about this because I'm really passionate about this, because in the past, ladies were identified as not having MIs at the same rate as men, when in reality, that's one area that the genders are pretty much equal. It's just that the symptoms were different and we were misdiagnosing females and they were dying. And so, again, we'll talk more about why diabetics, not totally understood as to why females have these different types of symptoms other than the chest pain. Understand that cardiovascular disease is still the leading cause of death in the United States. It is partially a genetics type of disease, but it is also partially a lifestyle disease. So, for example, as I've shared with you, you can look at me, you can tell I'm not the poster child for healthful living. I have a lot of cardiac issues. As a matter of fact, 2 years ago, I was teaching advanced cardiology to my students up in 286, and I had a heart attack. And I denied it. My stomach's burning. What's going? And finally, I realized that I was having a heart attack, and cancer class went down and had Hillary drive me over to the hospital, and I had a 6-inch clot in my right coronary artery. So part of my problem with my cardiac issues is cardiac disease runs rampant in my family. There's nothing that I can do about that. Lifestyle issues, though, I can, and I'm trying to work on those. Trying to eat less, trying to lose weight, trying to get more exercise, trying to reduce stress, trying to get enough sleep. And so these are the things that you want to kind of keep in mind. One of the things that we need to do in EMS that our fire department brothers and sisters have done really, really well is they've just about educated themselves out of fighting fire. 20% of the calls that a fire department will run today are fire related. The other 80% are all EMS related. Why? Because they've advocated for education. They've advocated for changes in construction material so that fires are not as prevalent today as what they used to be, nor are they as serious. We got to do the same thing, folks. As paramedics, you need to be educating the people around you, your friends, your family. You need to be educating your patients when they ask questions about different disease processes so that we can be part of the solution to reducing all of that coming down. Now, one of the things to keep in mind is that the majority of people who have a heart attack and go into cardiac arrest still die outside of the hospital, but that is changing. We have ambulance services even in our region, such as over at Boyle County in Danville, in Jessamine County in Nicholasville, up in Scott County in Georgetown, that are taking a close look at what they can do to increase the out-of-hospital cardiac arrest survival rate. In the past, if you suffered a cardiac arrest, it was almost assured that you were going to die, okay? But today, in those particular counties, they've got a survival rate of anywhere from 12 to 15%. Now you're thinking, well, that's not much, but it's a whole lot better than what it used to be, and that was zero. And especially if you or I are one of those cardiac arrest survivors, it's going to be important to us and to our family. One of the places in the United States today that is the safest place to have a cardiac arrest is Seattle, Washington. Because for decades there, they have promoted bystander CPR, early AED access. And now they estimate that if a person falls and goes into cardiac arrest, it will be less than 1 minute when somebody in that community comes by that knows how to do CPR and knows how to operate an AED and will have access to an AED. I fly a lot, too much as a matter of fact. So I love looking at where AEDs are in airports. In Atlanta, when I worked in Georgia, Atlanta was one of the first airports in the nation that just basically blanketed their airport with AEDs. AEDs being able to deliver electricity in ventricular fibrillation. You could literally, now it's not true today, but you could literally stand at one AED, look to the left, look to the right, and see your next AED before you left that one. If you walk down to that one, you could do the exact same thing. And so one of the things that we have to do, and again, in Seattle, the survival rate is about 60%. So it's really, really high. So what we have to do is that we have to be able to teach people, and with bystander CPR, chest-only compressions, that has made a big difference, because again, if I don't know the person, I'm going to be very reluctant to do mouth to mouth. It's kind of like, I just don't know what kind of diseases I might pick up from you. But doing chest compressions, the possibility of getting any kind of a disease from that alone is almost non-existent. So what are we going to learn in this module? Okay, these are your learning outcomes. I'm not going to go over them because they're in the slides, either the handout on the slides or the slides that are on Blackboard. But here's the thing I want you to know. This is where your test is coming from these objectives, okay? So your next exam will include material that probably will be about 75% EKGs and about 25% material starting today and moving forward. So make sure that you're going through and you're understanding that. So let's learn some new definitions. First one is we're going to talk about acute myocardial infarction, okay? Acute means what? That's not what I am. Acute means what in the medical term?
Happening at one time.
Tell me a little bit more.
So repeated would be chronic, whereas one time.
Okay, gotcha. Good. So it's a sudden onset happening at one time. If it is a repeated type of thing, you're exactly right, Travis, it will be considered chronic. So acute means a sudden onset, okay? Myocardial. Myo refers to what? Muscle. M-Y-O is muscle, okay? Cardial is the heart muscle, okay? So we've got something that's happening really, really quickly with the muscle of the heart. And we're going to talk a little bit about anatomy and physiology of the heart in just a little bit, okay? Infarction. What is infarction? What does it mean? Because you can have an acute myocardial infarction. You can have a bowel infarction. I got a friend who just told me he had a spleen infarction. Go ahead. Death of tissue, okay? So infarction always means death of tissue. Another word that is very similar to that we will use in this class also is called necrosis. Necrosis. Necrosis, okay? They both mean the same thing. Infarction, tissue dies off. Necrosis, tissue dies off. Now let me see how well you all were listening. What happens or what does cardiac tissue not do that has infarcted? Two things. Does it conduct electricity? And now in the heart, the pulse is going to be down here. But what else does the heart not do? Travis. Contract. So there's no mechanical activity and there is no electrical activity. So, then, Dr. Young, where does the electricity go? Because a person can have a heart attack. I just told you. I had a heart attack while I was teaching cardiology. Okay? Kind of ironic. But I'm still here, mostly. I still got electricity that's going through my heart. Where's it going? What do you think, Sydney? That's all right. Remember, I don't know is always an appropriate answer in here. Yes? Remember, if the electricity stops, the contraction stops as well. So what happens to the electricity in the heart when we have dead tissue, necrosed tissue, infarcted tissue? Say it again. Yes, you did know. It will find new tissue. Let me illustrate it to you this way, okay? Anybody get stuck in I-75 yesterday when the power lines went down across Athens-Boonesboro Road? So anytime you go up, if they shut down, if you're headed up north to Lexington, okay, and we're at Richmond down here. If you're headed north, and this is the exit out here off the bypass, and there's a wreck, and it gets shut down, what do? Say it again. They redirect. So you may come up here and go out, take a side street, and then go up on Highway 421, or you may take a different route. Well, guess what? The heart is designed to do the exact same thing. The heart is designed so that we can keep living when we do bad things to it. Okay? And so the electricity will go a different way. Yes?
I was just going to ask if it's possible for the electricity in the heart to conduct to some other surrounding organ, like the lung.
It is conducted, because remember, how do we get an EKG? What are we looking at when we get an EKG? That's a really good question, by the way. How do we get an EKG? What are we looking at?
It's movement of electricity
To where?
between the heart.
But our electrodes are on the outside of our skin.
surely then some energy must reach your skin.
Yes, it does. You're exactly right. Thank you. So the answer to your question is yes, it does. It does get conducted out to other organs, primarily going to be the lungs and maybe the diaphragm. But now here's the thing to remember: that electricity is so minute, it's not going to interfere with the action of those. So if we were to go in and we wanted to be able to do so, we could actually put electrodes on the lungs and we could see the electrical activity of the heart. Our problem with the lungs would be is that they're always moving. So the fact that, just like you said, and correctly I might add, that electricity is relayed out to the surface of the skin, that's what we're picking up with the little sticky things that we put on a patient's chest, okay? So again, when we're looking at this, remember, this is critically important. We either have a change in the passageway of the electricity. Why is that important, Dr. Young? Well, in the fall, some of y'all are going to be coming into my advanced cardiology class. I love teaching cardiology, my favorite subject. And we're going to take these EKG strips that we looked at, and we're going to look at 12 of them at the same time. Same view of the heart, same snapshot in time of the heart, but 12 different views. And when we are able to identify that detour that the electricity is taking, we can go, Travis, aha, you're having a heart attack. And I can tell it's in the bottom part of your heart, or it's in the side of your heart, or it's in the front of your heart, or it's in the septum of your heart, by seeing the changes that you've already learned of how the normal conduction is going to be, okay? What is the other problem with a reduction in the contractile force? Why is that a problem for our patients? What can that lead to? Travis? It all boils down to cardiac output. Cardiac output, same thing as perfusion. When we have a certain amount of the heart that is negatively affected, that dies off, then our patient's quality of life begins to be negatively impacted, okay? And as a result of that, what happens is the patient, maybe they're not able to walk around as much as like what they used to. Maybe they have some chest pain. Maybe they have some shortness of breath. Maybe they have to be on the chronic application of oxygen for the patient. So what does that mean for you as paramedics? It's important for you to remember this little mnemonic. Time equals muscle. When we're talking about the brain or we're talking about the heart, the longer amount of time that goes by that the heart is deprived of oxygen or the brain is deprived of oxygen, the more muscle is lost. Now, we don't think about the brain as a muscle, but the exact same principle comes in and applies there. So time equals muscle, all right? So that means we've got to be quick. We got to be quick with our identification and our diagnosis. And yes, you all will be diagnosing. We have to be quick with our appropriate treatment. We have to be quick for our transport to the appropriate facility, as well as how we're going to get our patient there. Is it quicker for them to go by ground, or is it quicker for them to go by air? Air is not always quicker, all right? So again, that is the key thing here that we're talking about with this acute myocardial infarction. Acute coronary syndrome is kind of an umbrella statement that deals with anything that has to do with the heart. And this could range from your patient having chest pain as a result of a myocardial infarction, or an MI or an AMI. That's the appropriate abbreviation. Or it could be because it's not the arteries are not completely blocked off, and what is happening is your patient is having angina. We'll talk more about angina in just a couple of seconds and much deeper as we get into this particular lecture. Aneurysm. Think about a balloon, okay? And think about if you fill a balloon up with water. What happens to the balloon when you fill it up with water? Say it again? Yeah. And so is it easier to break a balloon with water or a balloon with air? With water, yeah. So with the one with water, it's much easier to break. An aneurysm basically is a bulge that takes place in the wall of an artery that leads into the potential for it to break. Now think about it this way. Arteries have three sections, okay? The outside of the artery is called the tunica adventitia. The tunica adventitia is tough. It's fibrous. It does not contract. It does not dilate. It is leather-like. It is protective of the artery itself. On the very inside here, we have the tunica meaning Latin for covering, tunica intima. The tunica intima is the lining of the artery. Every one of us in here when we were born, our arteries were completely clear. No fat, no cholesterol, no plaque. As we get older, depending upon our lifestyle, depending upon our genetics, now that begins to change. But the lining of the artery itself is very slick. It's kind of like Teflon. And when you've got really good Teflon, what sticks to it? Not a thing. Not a thing. Okay? That leaves us with the middle of the artery that is known as the tunica media. Again, Latin for middle. The tunica media is the muscular part of the artery. This is the part that will constrict and dilate. All right? Constricts and dilates. What happens in an aneurysm is that, we'll do a cross section here now. Okay? This is your tunica intima. And what happens is, and here is your, tunica intima. And this is your tunica adventitia. What happens now is you get a tear or something in here. And remember, blood is flowing in the artery. Is the blood flow in the artery high pressure or low pressure? It is high pressure, okay? Because it's getting pumped out there by the heart. Veins, low pressure. So they're very floppy, all right? So you kind of remember that. But as we get this, and we get this tear that occurs in here, now blood begins to accumulate over in this area here where the tear is, and it begins to, technical medical term here, pooch out, okay? It begins to bulge out. And as it bulges out, guess what happens, Travis? It gets weaker and weaker, the surface of that. Eventually, if that ruptures, our patient can have several different problems. If it is part of the aorta, your patient will be dead in about 5 seconds, okay? If it's in the brain, then our patient has what's known as a hemorrhagic stroke. None of these are good. Yes?
So you're saying that it would kind of flood underneath the tunica adventitia?
Yes, exactly right. So what it would actually look at like here is that as this blood continues to accumulate and going into here, this is what your tunica adventitia would eventually look like.
So then what would it do to the muscular part of the
Y'all make me so happy. You ask such good questions. I don't know. What do you think it would do? You're talking about the muscular part right here? What do you think it would do? So it's causing trauma. And what happens when we have a torn muscle? Say it again. It gets weaker. What does a torn, weak muscle not do? It wouldn't contract. So again, this is why it makes it even more dangerous in the fact that it can rupture because it won't contract. It won't slow down. Excellent. Does that help? Perfect. Okay.
If it doesn't contract, does that kind of, I guess you could say, lower the chances of it rupturing?
It does. It does. And it also depends upon the size of the artery. Again, as the aorta comes up off the top of the heart and goes down through the chest, the abdomen, and then bifurcates into the femoral arteries, as it comes out of the heart, your aorta is about the size of your thumb. That's a lot of blood, okay? Up here in the brain, the vessels are much, much smaller, okay? And so you can imagine if we suddenly cut off the blood supply from an artery that's the size of your thumb, as opposed to like a microscopic artery in the brain that ruptures. So it all depends upon the size of the artery that ruptures. Excellent. Very, very good. Aortic dissection is just exactly what I just shared with you. Dissection meaning you get a tear in the lining and it opens up. Your patient now begins to bleed. Yes?
Is constriction the same as contraction?
Mm-mm.
Because you said that the arteries don't contract, but they do constrict.
Okay, so contraction is in this class refers to the mechanical, and many times, and don't be afraid to call me out if I get them mixed up. You are not going to make me mad. So when the word contraction refers to the mechanical action of the heart. Constriction means to the narrowing of the diameter of blood vessels, primarily arteries. So that's the difference between those. Because they're so similar, sometimes I get them mixed up. So if I get them mixed up, hey, Dr. Young, are you sure that's what you mean? It's okay. All right. Thank you. So, any questions on these words? Kind of. A triple A, which is an abdominal aortic aneurysm. Remember, the aorta comes off, comes up this way, goes down behind the heart in the chest. So we can have a thorax, an aneurysm in the thorax. But more commonly, what we see is that if we get an aneurysm, it's going to be down in the abdominal area. Now, we'll specifically talk about aneurysms, triple A's, in the abdomen a little bit later on in the semester. But a triple A, when you hear that refers to an abdominal aortic aneurysm, which is basically a ballooning out of the aorta as it passes through the abdomen. Good question. All right. And remember, an aneurysm does not mean that your patient dies. A lot of people live with aneurysms that have perfectly normal lives. It just simply means that we've got this bulging of the artery here. Okay. Many times an aneurysm is stable and they'll watch it. Okay. Other times it becomes unstable and they go in and they repair surgically. Any other questions on these words? Asystole. We've talked about asystole. Asystole basically means the absence of any electrical activity. Okay? There's no electrical activity. There's no mechanical activity, which results in what on the monitor? Flatline. Or the other name for it is? What's the other name for flatline? There it is. Don't make me cry.
Oh, is this good?
Asystole. Okay. Atherosclerosis. If you're from the South, we have perfected atherosclerosis because we like butter. We fry everything here in the South. Boy, it tastes good, but it is not good for our hearts. It's not good for our vasculature. Okay, we fry things from like Twinkies. I've had a fried Snickers bar. It's okay. Had a fried Oreo, and that wasn't very good. But somebody got smart and said, "Hey, let's fry butter." That didn't even sound good at all. Period. Okay. But again, atherosclerosis is caused by two things. Okay. Number one, we begin to get deposits of cholesterol and fat that link up onto the walls, the tunica intima, the walls of the artery. Okay. And what that does is that keeps the arteries from being slick. Okay. And if it tears, now a clot begins to form. And more material begins to attach to that. More plaque, more cholesterol, more blood. Over a period of time, a thrombus begins to develop or plaque begins to develop. When you go to the dentist and the dental hygienist comes in and cleans your teeth, that's not really the most pleasant part of going to the dentist because she will take a little scraper thing and she'll scrape because plaque is hard. If we were able to open up the heart and pull out a piece of plaque and I handed it to you and you rubbed it between your finger, it'd feel like a little teeny tiny gravel. Very hard, does not compress. The other thing that happens along the same line, which comes right into what you asked a minute ago about what happens to the damage to the muscle, is now this muscle becomes damaged, it becomes thick, and it doesn't work. And when a muscle doesn't work, what does it not do? It doesn't what? What does the tunica media not do in the artery when it becomes thick? It doesn't constrict, nor, more importantly, does it what? What do arteries do? They pump blood, but they constrict and they do what? They dilate. More importantly, the artery doesn't dilate. If an artery cannot dilate, what kind of problem does that lead to for our patient? High blood pressure. Yep, you're exactly right. So it's a vicious cycle. The artery cannot dilate to lower the blood pressure. The blood pressure goes up and it makes more damage to the artery. And so we get more and more and more sections of that artery that gets damaged. Less and less and less parts of it is able to dilate. And it leads into all kinds of problems. It can lead into blindness for our patients. It can lead into heart attacks. It can lead into strokes. It can lead into renal failure. And again, so this is why controlling your blood pressure is so very important. We'll talk more about that in just a little bit. Cardiogenic shock. Now, remember, what did I tell you? Kind of a review here. What did I tell you were the two things that dead tissue could not do? Dead cardiac tissue could not do. Say it again. Conduct electricity or no mechanical action. The problem with cardiogenic shock is that this is shock that comes about as a result of the failure of the heart as a pump. The most common cause of that failure of the heart as a pump is a myocardial infarction. Too much tissue dies off, and as a result of that dead tissue, the pump no longer works effectively. It can't get blood out. Travis, as you said earlier, perfusion drops, cardiac output drops, and our patient is negatively impacted on this. This is a type of shock. As you're moving on in, and for those of you that are EMTs, you've covered many of these types of shocks, such as cardiogenic, anaphylactic, hypovolemic, hemorrhagic, obstructive, distributive. But this is one of the types of shock that is really, really dangerous for your patients because, again, the heart fails as a pump and it does not pump forward. Next word, we're going to change up just a little bit. Always in the past, up until about 5 years ago, this has been known as congestive heart failure. Now it's just referred to as heart failure. You will still see medics of my generation, and you will hear me referred to it as well. Old habits are hard to break, as congestive heart failure or CHF. Whichever way you want to call it, I'm okay. It's all right. Okay. I'm trying my best to get with the new vernacular, but again, I've been doing this for over 40 years, so it's hard to get into the habit of using new terminology. But congestive heart failure happens when the heart fails as a pump, which often leads to what did I just say? Which results in what, Travis? Which results in what? I can do this all day. What type? Cardiogenic shock. There you go. Okay. The other thing that we see here is because the heart does not pump really well, the blood that is in the heart now begins to back up. I got a whiteboard here. Well, I guess I got this right here. And no eraser. I got to go to the board here. I'm not an artist, but this will be easier for you to understand. So we're going to go back to way back to the beginning of class. Remember when I drew this up here for you? This, as far as the heart, is the what? Okay. So blood comes into the heart by way of the what? Vena cava. Okay. Drops down in from the right atrium into the right ventricle through the tricuspid valve. Then it leaves the right ventricle and comes over here to the lungs. Okay? When it goes to the lungs, now it comes back to the left atrium, and then it gets dumped down into the left ventricle through the bicuspid valve, out through the what? Where does it go when it leaves the left ventricle? Aortic valve. Okay, good. Into the aorta. Now, we all drive. We've all been in traffic. We've all been in problems when traffic backs up. Let's say that for whatever reason, we have a significant portion of our left ventricle that dies off. Now take me step by step through what's going to happen from a physiological perspective or from a traffic perspective, okay? If the left ventricle, let's say it loses a third of the left ventricle, it's dead. Not conducting electricity and not pumping. what's going to happen?
Blood's going to back up
Where?
on the right side of the heart.
Not yet.
It's a left ventricle, right? Or in the left atrium.
So we're going to begin to get blood that's going to back up here. If we don't get it fixed, you're exactly right. Then it's going to begin to back up here into the left atria. If we don't get it fixed, what's next? The lungs. So the blood will begin to back up into the lungs. This, my friends, is known as heart failure. Heart failure is simply the failure of the heart as a pump. When it fails, blood backs up. We go out on the interstate. Got on the interstate this morning, come up through Lexington and was coming down. No, the interstate just north of Athens, Boonesboro was still closed. Guess what I saw? Traffic was backed up. And guess what they were doing? They were trying to get off at the Athens, Boonesboro exit, but it was backed up, backed way up. If traffic continues to come in there, eventually, where is that traffic going to back up to? And then where? Say it again. And then where? And by saying and then where, I'm agreeing with you. And then where? Yes. So the exact same thing happens here in heart failure, okay? Left ventricle fails. It begins to back up into the left ventricle. It doesn't work. It begins to back up into the left atrium. And again, if the left ventricle is not pumping, it backs up into the left atrium. Now it backs up into the lungs. What type of sign or symptom do you think that you would experience that would let you know that you have heart failure going on?
Fluid in the lungs.
Say it again.
Fluid in the lungs.
How would you know that?
Auscultated.
Auscultating, okay? So, in this situation, what you would now begin to see, there it is. What you would begin to hear is a condition that is known as rails or crackles. They are the same thing. Again, terminology changes, and sometimes it's hard to change with what the terminology is when you've done this for so long. So rails or crackles. Rails is an old term. You will often hear me refer to it. I'm trying to stay with crackles. But rails is what you hear when you put your stethoscope on the patient's chest and you hear this popping noise. And this is what it sounds like. It sounds like, Carson will say, when you get done here, maybe you've already had lunch, or maybe you're thinking, man, I wish he'd hush so I could go to lunch. You go get to your favorite place, you get a hamburger, get some french fries, you get a Coke, you get a Pepsi, whatever your favorite soft drink is, and it's got some ice in it. And you're finished with your meal, and you're getting that last little bit of your soft drink in your ice that's left in the bottom of your cup through your straw. That's exactly what rails sounds like. Look at me, I equate everything in the body to food. This is probably why I've got all this right here. So think about that when you go to lunch here in just a little bit. When you get to the bottom of your cup and you hear that popping noise, Sydney, of getting that Coke or Pepsi or whatever it is, your tea that you're trying to get in, you begin to think, that's what Dr. Young meant. That's rails. That's crackles. That means that it's in the lungs. That sound indicates a condition that is known as pulmonary edema. Now, this is not on your word list, but this is important. Pulmonary edema, fluid in the lungs. Now, we can have thin fluid, we can have thick fluid. We'll talk about thick fluid later. But for right now, for cardiac, the fluid that you're going to hear in the lungs is usually going to be very, very thin. What is the problem with fluid in the lungs?
The air sacs in the lungs, right?
What about?
So that's why the fluid causes it to like pop. Alveoli,
Uh-huh.
like the fluid like builds up in them, and that's where
I know it's on the tip of your tongue. Bingo! Yeah, diffusion takes place in the alveoli, the air sacs. It's a principle of physics. A gas and a liquid cannot occupy the same space at the same time. So if there's liquid in there, guess what's not in there? Oxygen. Okay? And so when we have liquid in there, that decreases the amount of oxygen that's available for our patient. Okay? Very good job. Very good job. Right? Coronary artery disease is just another kind of an umbrella term that indicates that there's something going on either with the heart or with the vessels that come out of the heart. We can also often hear this called cardiovascular disease. Okay? Diaphoresis, we've already talked about. Dyspnea is DYS, difficult. PNEA, air, difficult air, difficulty breathing. It can be mild, it can be moderate, it can be severe. Dysrhythmia or arrhythmia means the same thing. That's what we've been studying all semester long, and you guys have done really, really well, which I expect to see really good grades. Catherine, as soon as I can grade them. I'm working on it. I like to pick on y'all. Infarction, we've already talked about. Infarction is what? Death of tissue. Don't say death of cardiac tissue. Death of tissue. You have infarction, death of tissue. That tissue's not coming back. And then you have the word underneath it that is called ischemia. Ischemia means that we have a reduced amount of oxygen that's going to that tissue. In the world of cardiology, that's what we often see with patients that are having angina. We have a reduced diameter of the lumen or the size of the arteries in the heart. So we have reduced blood supply. When we have reduced blood supply, we also have a reduced supply of what? Oxygen. And so the cells begin to starve and they begin to have some chemical changes that will result in pain or discomfort. Ischemia, we can bring that back if we act fast enough. That's what we're trying to do. Yes, sir.
Are infarction and necrosis interchangeable?
Yep. Now, when you're talking about heart attacks, generally what you're not going to say is you're not going to say, oh, well, this patient had a myocardial necrosis. But quite often when you're discussing with other medical professionals, you'll say, well, yeah, he had necrosis of the left ventricle, things like that. So necrosis and infarction are just basically to say the exact same thing. Good. All right. Myocardium, we've covered. Necrosis, we've covered. Pedal edema. Now, where do you think you would find pedal edema other than looking at the definition? In the feet. Now, pedal edema comes about as a result of heart failure. Okay? Now, remember, we talked about if the left ventricle fails, blood begins to back up into the left ventricle. Eventually, it'll back up into the left atrium. Okay? Eventually, it'll back up into the lungs. It doesn't stop there. If this gets even worse, where is it going to now begin to back up? It's up here.
Does that mean to the right ventricle?
Yeah. It'll begin to go into the right ventricle. If it doesn't get taken care of, then it moves where, Travis? Up here to the right atrium. And then if that doesn't get taken care of, it moves out into the body. And the way that we see this, and this is really quite serious, okay? The way we see this is that, again, fluid will follow the laws of gravity. So fluid will have a tendency to collect in the lower extremities. That is known as pedal edema. That is often a sign of right heart failure. Okay? So we split this down the middle here. We have left heart failure, which one of the signs is this right here. And what did I say this was called? It's one of your words that's coming up. What is this called? Pulmonary edema. And then if it comes back over here and it causes right-sided heart failure, now it results in pedal edema. Edema down in the lower extremities. Yes, sir.
So if there's so much fluid buildup in the heart or in the lungs, you see vomiting blood.
You sure good. Not so much vomiting, because remember, vomit comes from here, but if your patient coughs, they'll have little specks of blood in the sputum that they will cough up. Mostly of what is up in here is actually plasma with a few little red blood cells.
I've witnessed this before at its work. It's kind of like a waterfall.
Tell us about it.
We went on a call to a residence for trouble breathing, and I was kind of excited because usually trouble breathing is not too tough. It's kind of fun. You get to do medications. And we get there, and it's a little worse than trouble breathing. So the gentleman was up on his front porch. His niece had called us, and he was sitting on his front porch chair, and he was kind of tripoded like this, leaning over, and he was already very gray, and he was just kind of. And so we run up there. It was me, another EMT, and a medic. And we had the stretcher. We get up to the front porch, and we just were immediately like, we got to get this guy going. We didn't even think about it. So me and the other EMT, we get our arms up under his shoulder, and he kind of steps with us. We get him on the stretcher, and I go and I pick his legs up. And the moment I pick his legs up onto the stretcher, I look up at his face, and his eyes roll back, his head rolls back, and fluid just starts gushing out of his mouth. And it's pink, and it's bloody, and just, so he died. He did not live. We did CPR and a lot of suction and a lot of meds, the full code. But yeah, I mean that's what it was. He was very overweight. He worked at the Shell station. I presume he ate a lot of food from the Shell station.
From the Shell station.
Yeah, and he had the edema in his legs, and my guess is while he was sitting there, his lungs had probably just filled up with fluid. And when we tipped him back on the stretcher,
You're right. And you didn't do anything wrong. You had to get your patient on the stretcher because had you walked your patient to the ambulance, he would have probably arrested anyway. But again, you're not going to forget that, are you?
No.
And this is why, ladies and gentlemen, once you get your EMT, I want you to go get a part-time job. Because I can give you all these signs and symptoms here, okay? Or, it's kind of like, okay, I can't remember what Dr. Young say about, it's the left-sided heart failure. Oh, yeah, and I hear pulmonary edema. Yeah, that's what I hear. And it's crackles. And then, I got to look at their feet, okay, for pedal edema. I got to remember all that. Or you can say, well, that was Mrs. Jones. We transported her last week. I know exactly what that looks like. So, again, if you don't have a part-time job now and you're able to get one as an EMT, and you're an EMT now, or if you're finishing up your EMT, getting ready to go in the sequence, come see me. We'll get you in places where you can work. That'll be a good learning experience for you. Last thing I want to put on here as far as those pulmonary edema, last thing we're going to talk about on here is vasospasm. Remember, we talked a little bit about Prinzmetal's angina. Prinzmetal's angina comes about as a result of a person that is usually using what kind of drug? Meth, some type of amphetamine. And it'll cause a really tight constriction of the artery. So a vasospasm is, think of it as a cramp in the artery, and it narrows it down. And when it narrows it down really, really small, you barely have any blood going through, and that causes ischemia. And ischemia is what? Poor oxygen. Can we fix ischemia? But if we don't fix ischemia, it leads to what? Go to lunch. Good job. Good job. I'll see y'all on Monday. Remember, you will have a 10-question EKG quiz on Monday. All right?